Hello, good evening, good day to everybody following us on the Dubai Shoulder course webinar series. This is one of our webinars talking about AC joint dislocations. So here from the webinar base, we have two major famous surgeons who will talk to us about AC joint. From Switzerland and Germany, we have Professor Markus Scheibel, who will talk about the acute treatment of AC joint dislocation and the latest trends in that field. And from Toulouse in France, world-known Dr. Kany will talk to us about how he manages the chronic AC joint dislocations. So for 10 minutes each, we will have certain talks which will leave ample time for questions and for discussion that we can have amongst us. We can have a very nice debate between Dr. Scheibel and Dr. Kany, as their techniques differ slightly of how they treat these sorts of treatments. So without further ado, I would like to invite Dr. Markus Scheibel to start his talk about acute management of AC joint. We are joined also by my colleagues, Dr. Osama Saleh from UAE and Dr. Ali Al-Suwaidi from UAE, who will co-moderate this webinar. I hope you enjoy. Please don't hesitate to ask any questions if you have any.
Thank you very much. It's a great honor and a great privilege to be with you so far away, and obviously during a different time. And I'm happy to be one of the invited speakers together with Sean Kany. And I would like to start my presentation with maybe some new ideas about a diagnostic of AC joint instability. And these are my conflict of interest. As you know, Rockwood's classification is a classification that is widely used. When you deal with this classification, then you can more or less include most of your patients that you see in the daily routine into these 6 categories, mainly 5, of course. But what is interesting is that there is only one type of the Rockwood classification, type 4, that encounters posterior translation of the clavicle. And this is, if you read in the Rockwood's paper, it's a locked posterior displacement of the clavicle. So there is nothing in the Rockwood classification about dynamic posterior instability. So what do? We do, of course, stress AP views. We measure the CC distance and we compare it to the opposite side. And since many years, we are doing these horizontal instability Alexander views, as you can see on the lower left. And what happens is you put some stress on the clavicle and you bring the scapula forward. And this leads to translation of the clavicle over the acromion, which resembles more or less a posterior, dynamic posterior translation. So right side is a normal side, left side is the unstable side. So I show you some cases. This is a Rockwood type 1, you see here, stable on the Alexander views. This is a Rockwood type 2 measured by the CC difference, stable on the Alexander view. This is also a Rockwood type 2 injury measured by the CC distance. However, there is a gross instability on the Alexander view. So these two Rockwood type 2 injuries might be complete 2 different entities. Same is true for the Rockwood type 3. Look at this Rockwood type 3, according to the CC difference, stable on the Alexander view. Now look at this Rockwood type 3 injury and look at the Alexander view, different. So there might be low-grade instabilities who do have a posterior dynamic component that is not encountered in Rockwood's classification. One is clear: if you have a Rockwood type 5 injury, all of these patients are horizontally unstable. So if you don't want to hurt your patient more by X-rays, you just avoid Alexander views because you know when you have a type 5, there is no need for Alexander views since you have posterior translation. So we came up with this new classification of acute AC joint separation. And why did we come up with this? Because we looked at prospectively acute instabilities, 52 cases. You see, according to Rockwood, 4 type 1, 5 type 2, 21 type 3, and 22 type 5. And we looked at these same patients who are also posterior unstable on the Alexander views. And you see on the Rockwood type 5 and on the Rockwood type 3, and particularly Rockwood type 3, 2/3 of these patients are slightly or grossly unstable on the Alexander view. So there is definitely a need for a new classification system, and we came up with this specific classification that we are currently now prospectively evaluating. We divide the vertical displacement below and above 30% with and without dynamic posterior translation. I will tell you in 1 or 2 years if this is really something of value. So what did we learn? We also learned that the patients do have concomitant clean room pathologies if you treat acute Rockwood type 3 to 5 injuries. We looked at 125 patients, average age 38.5 years, mainly Rockwood type 5, as you see here. And we found 30% of glenohumeral pathologies. Acute lesions that we called acute were just 7.2%. You see here on the left side, upper subscapularis, avulsion of the supraspinatus, reverse Hill-Sachs lesion in a combined posterior subluxation of the glenohumeral joint. Degenerative lesions in 14.4%, and intermediate lesions where we didn't really know if this is acute or chronic in 8.8%. Of course, we don't know if we have to treat these injuries. There is absolutely no evidence. But now, since we're doing this arthroscopically, we see them, and if we decide for repair, obviously we repair them. So how do we treat this? In December 2006, so that's 15 years ago, we started to do the double tightrope technique using the old syndesmosis tightrope. Double tightrope to recreate the course of the ligaments. And we did not address horizontal translation. And looking at the results of this particular technique, they were pretty good, in fact, in terms of clinical results. However, very disappointing in terms of radiographic results. We had around almost 50% of posterior dynamic translation at more than 2 years follow-up in these patients. So the idea was to add stability, and so we, as you see on the right side, the middle image, we combined the CC stabilization with 2 tightropes with a horizontal AC cerclage. And together with colleagues from Bern, we evaluated this technique biomechanically, and you can see that the double tightrope repair plus AC cerclage is, in terms of ultimate load to failure, the most stable technique. So since we thought this has additional value, we looked since January 2009 until March 2016, we looked at patients with this technique, and we published this technique. And the clinical results were, I would say, comparable to the results that we achieved with the just double tightrope repair. However, we could show that if you add an additional AC cerclage, the rate of complete posterior recurrent instability is lower compared if you just do 2 tightropes. There is one bias, since in the second study we used the 2nd generation tightrope and not the 1st generation tightrope. So that's the bias of the study. But we feel that there is some value of this additional cerclage. So looking in the literature, what kind of problems do we have? This is a nice paper that basically summarizes the problems that we do have currently with arthroscopic fixation using mainly double button systems. Loss of reduction, so you can tell your patient in 25% you might have some recurrent instability. Implant irritation, 1 out of 4 patients has implant irritations on top of the clavicle. CC calcification, I don't know if this is a complication. I think it's actually sometimes desirable to have it. Obviously, fracture is a problem. Infection can be a problem, of course. So why did we change? We changed because of the results that you have seen, and also because of the complexity of the procedure. 2 tightropes is difficult for someone who is not doing arthroscopic repair every day. 2 tunnels, placing them ideally under image intensifier and arthroscopic control has quite a learning curve. So to simplify the procedure, 1 tunnel might be sufficient if you use an additional cerclage. And we developed this so-called low-profile tightrope in order to avoid problems with the knot stacks, to avoid implant irritation and wound breakage. So the low-profile tightrope that you see here with the top head button allows to place your knots inside the top head button. You can place actually 3 to 4 knots into the upper aspect of this button. And another thing is, what we just recently seen in a study, that while not allowing contact between the suture material and the bone around the top head, in particular of the cylindric part, there is no tunnel widening. So this technique is something we are currently exploring. It has a very high fixation strength of around 1080 newtons. And I briefly show you the technique. We look from a lateral portal. We come with the guiding device. We place the superior drill bit central part of the clavicle. We do every drill hole under image intensifier control. You can use this 2.4, 3.0 drill with a K-wire inside, or you can also use a 2.0 K-wire that you over drill with the second drill. And this is, as you see here, a 5.1 millimeter drill, just to open the superior aspect of the clavicle, so the superior cortex. Then you remove the K-wire, you insert the retinol wire that you retrieve via the anterior-inferior portal. So basically the drill hole is made. It's a very small drill hole. And now we are placing the guiding device via the superior incision and into the anterior-inferior portal. Place a 1.25 millimeter K-wire from anterior to posterior. And we over drill it with a 2.7 millimeter drill under image intensifier control. And we insert an retinol wire from anterior to posterior, exiting superiorly. The same, what you've just seen, we do transacromially, so a 1.25 millimeter K-wire exiting at the superior incision. We over drill it with a 2.7 millimeter drill under image intensifier control, and we insert the retinol wire. So we don't do any more incisions for the cerclage. So these are the 2 tunnels for the cerclage. Now you have the low profile tightrope, as you can see here. We use the first retinol wire to shuttle the fiber wire through the clavicle and through the coracoid, exiting anterior-inferiorly. Then you have the stock bone button that now, with pulling the device superiorly, it blocks underneath the coracoid, close to the base. You remove the pulling suture. And then, slowly but surely, you pull on these sutures, and the top head button migrates into the superior drill hole. And then we use, this is not shown in this video here, a tensioner up to 80 newtons to, in fact, get some little bit of over reduction, as you can see here, 2 to 3 millimeter over reduction. Then we do the final knot tying. We cut the sutures, and then basically the CC stabilization is done. Now we use a fiber tape that we shuttle from anterior to posterior through the clavicle, and then from medial to lateral over the AC joint through the acromion. And then there's a nice little trick. You use a knot pusher that you insert over the ends of the fiber tape to exit these fiber tapes both at the superior incision to avoid any soft tissue engagement. And then finally, we do the horizontal cerclage. So this is really a minimal invasive technique, as you can see here, with some 3 incisions. So I can tell you now that for these low profile tightropes, the results have not been evaluated now up to 2 years, but the early results are very promising. What we also have looked at recently are predictive factors. All of you know that, for example, for rotator cuff repair, we have predictive factors for outcome. Fatty infiltration is a negative prognostic factor. Proximal migration of the humerus is a negative predictive factor, but we don't know a lot about predictive factors of healing and CC reconstruction in AC instability. So we looked at 104 patients. All of them had Rockwood type 5 injuries. All of them were operated in the first 3 weeks. We had 49 cc and 55 cc and AC stabilization, follow-up 2.2 years. We did regression analysis, and what we found was, number one, the age, timing of surgery, post-surgical reduction, and the technique of stabilization plays a role. With other words, the older the patient, there is no clear cutoff, but I would say above 50 is a discussion. Timing of surgery, the earlier you operate. Post-surgical reduction, meaning that if you over-reduce, and in particular if you do a combined CC and AC stabilization, leads to better radiographic results. So these are some factors that we do consider for the future if we go for additional tendon reconstruction. So to summarize, over the years, it's now 15 years that we're doing this technique, all the time arthroscopically assisted image intensifier control. It is safe. We never had a single neurovascular event. Good to excellent clinical results can be achieved. There is still a problem of recurrent vertical and or horizontal instability. We consider this a biological failure, in particular when this recurrency occurs after 3 to 4 months. Advantage of additional AC reconstruction, synthetic, as you have seen, we consider this beneficial. The role of the new implants need to be determined, but we are very positive, and prognostic factors that you have seen should be considered in the future. Thank you very much.
Thank you, Markus, for this very nice talk about the AC joint and acute treatment. So I will go directly to Dr. Kany. We will take the talk, and then we'll have a nice 20 minutes of discussion so that we can end on time and let you go back to your busy schedules. So please, Dr. Kany, if you can start your web video.
Is it okay? Is it okay?
Yes, we see very well. Yes.
Okay, thank you. So thank you. I am very happy to be here and to have a nice discussion with Markus. I will talk about the chronic AC joint dislocation. I have a problem with my, I cannot, okay. This is my disclosure. So maybe if you think like 80% of orthopedic surgeons that there is no indication of surgery in case of acute AC joint, I would like to show you that maybe you are wrong, because in the chronic situations, almost 20 to 40% of the people have some symptoms and have to take an elective surgery. And the results of a chronic case are not as good as the acute cases. So this is something you have to remember. And why did I show this picture of Hegel, who was a German philosopher? Hegel have published a lot regarding the dialectic, and the dialectic is how to learn with your mistake. And I can show you that I've made a lot of mistake in such a situation. In fact, for my topic, I would like to try to answer to these 4 questions. Why an arthroscopic procedure? What did I stop? How to prevent complications, and what about the AC joints, and what about the distal resection of the clavicle, and what about the cerclage in the chronic situation, like Markus in the acute situation. So why an arthroscopic technique? If you open the shoulder, especially the AC joint, it's very invasive, anesthetic, and the vision under the clavicle is not very, very good. Of course, it's very easy to see the AC joint, but you cannot see under the clavicle. If you use an arthroscopic technique, it's very easy to here. You can see under the clavicle, between the clavicle and the coracoid process. You can see under the coracoid process, you can see your graft, and you can control your AC joint. And this is very, very easier than an open one. So what did I stop? I've tried everything you can see here, Kirchner wires, screws, and I've stopped everything because you always have some problem, and especially you may have some stiffness because it is a joint, and if you fix something with a rigid system, it cannot work. You have to remove the screws, to remove the Kirchner wires, you may have some infection. So what did I stop to? The around coracoid fixation. Maybe you know such a system, a U shape under the coracoid process. And first of all, most of the time you have an anterior subluxation of the clavicle because it's not really anatomic. The second point is I've had a lot of failure, and you can see here this ligament. You can see here another failure. I have a lot, and I've published my failure. The problem is not the traction, the failure with the traction. The problem is the friction, and this is there is a problem just under the coracoid process, and I've stopped totally such a system. So what about the button and the tunnel? Of course, I follow the idea of Markus, and I try to do some tunnels like that. But as you know, with this paper and Markus have shown lots of complications. You may have the recurrences, pain, clavicle fracture, implant loosening, coracoid fracture, tunnel widening. Between 20 to 44% of complications have been described, and you have to understand what happened really. So to prevent this complication, in fact, I think first of all, you have to come back to the anatomy, and this is the draw of the first year of medicine. My daughter was in first year of medicine a few years ago, and I think the aim of this surgery is to reconstruct both the anatomic ligaments, and you have 3 ligaments, and we know perfectly now with this paper where are the insertion of the ligament and where you have to drill through the coracoid process, and the conoid has to be drilled 22 millimeters from the clavicle and 48 for the conoid, for the trapezoid one. And it's the same, you can see here, you have to drill as posterior as possible if you want to be anatomic and if you don't want to have an anterior subluxation of your reduction. Another point, and I totally follow the idea of Markus, you can, the disjunction, the dislocation is not only vertical, it is vertical and horizontal, but try to understand. If it's both vertical and horizontal, I think you may have what we could call a rotational instability. If you have a rotational instability, just one fixation is not enough, and I totally follow the idea that you need a double fixation. Otherwise, it cannot work very well. And last but not least, I would like you to remember these 3 last points. First of all, in the type 4, but sometimes, I don't know if it is the type 4, you have a soft tissue interposition, and you have to test your patient before the surgery, because if you have a soft tissue interposition, you cannot reduce, and especially if you do not control the joint during your surgery, you will have, with a swelling shoulder, you will have no possibility to control. You have to release this interposition. Another point is the posterior and log dislocation. If you make an anterior posterior X-ray, you think there is no dislocation, but it is a log and posterior one. As Markus just said it is the type 4, yes, but you need a CT scan and you have to release this joint and to control it. Another point, but this is only for the chronic cases, you may have an arthritis, very old arthritis, and sometimes it's not possible to have a very nice reduction. And the question is, do you have to do or not a distal resection of a clavicle? This is the technique I use, and you can see it's little different with the one of Markus. I am here just under the clavicle. So as you can see, I will not use any guide. For me, using a guide maybe it's easier, but it's very difficult for me to be exactly at the center part of the clavicle, at the center part of the coracoid process, to reduce everything. And for me, you have to make three things in the same shot, and it's very difficult. So I do not use any drill, but I make a Y shape or V shape, and there is one lateral tunnel, a 2.4 millimeters, so very small one, one medial one lateral one, and I graft with the CA ligament. This is an example you can see here, but I totally accept the fact and the publication of Markus. You can have a very nice superior vertical balance, but you cannot have a perfect horizontal balance. And for that, I think I totally agree. In acute cases, you must you have to control the AC joint, and you have to make a cerclage, an horizontal fixation in addition to your vertical reduction, but you have to control it, but I do not use the fluoroscan. But the question for me is still open. In the chronic cases, as you have a dysplasia of your joint, because it's a chronic cases, if you try a reduction without making a distal resection of the clavicle, sometimes you will have a problem in interposition. You will increase the pain onto the AC joint, and I'm not sure that in chronic cases you have to make a cerclage. In conclusion, I think I use a Y shape, but maybe only one ligament is okay. But I think we need a graft, and this is the technique of Pascal Boileau. I make a Weaverton procedure. I try to be as anatomic as possible with a double fixation to prevent any rotational recurrence instability with a very small tunnel. Regarding the AC joint stabilization, I totally agree with the fact that it is for the acute cases because you want an anatomic reduction, but I'm not sure for clinical case it's really mandatory. And welcome to the next Toulouse Arthroscopic shoulder course. Thank you very much.
Excellent. Thank you guys very much for having joined us tonight and today. It's a great pleasure to talk. We see that the AC joint is still a mystery and it's a really difficult joint to treat. And I thank Dr. Markus Scheibel and Dr. John Kany, who are working hard on developing many new techniques and giving us new data about these things, which one day we will all just decide that this is the correct treatment for such joint. And still an ambiguous joint with very difficult treatment and unhappy sometimes patients. Thank you guys for joining us tonight. I hope the audience enjoyed. I tried to answer all the questions that are there. And good day to all of you, and please stay healthy with the end of our pandemic. Good night, everybody.
Salut.
Thank you, Ali.
Salut,
Thank you,
Markus.
Sean.
Ciao, ciao.
Bye,
Salut.
guys.
Salut, Ali.
See you
Ciao.
soon.
Thank you, guys.